Good evening, everyone. Respected chairperson. So, can I have the slides, please? So, I'll be talking on total hip replacement in ankylosing spondylitis. I think everyone is doing in this hall very frequently the THA, but there is some special consideration has to be made in these type of cases, and as you all know that it's inflammatory arthritis which primarily affects SI joints and spine and hip also, and 20 to 40 years of age, and there is a hip involvement is around 30 to 50% and bilateral involvement is about 90%. So what our aim is in doing a THA in ankylosing spondylitis is to give a pain relief to our patients and eradication of the flexion contractures, which is very common in these patients. And of course, we want to give an increased range of motion of the hip joint, which improves the mobility and correction of posture. So these are our aim of doing a total hip replacement in these patients. So certain preoperative planning consideration is very, very important. Always anticipate difficult spinal anesthesia because the spine is very stiff. Even the neck is very stiff, so intubation may be a difficult one. So always ready for the nasal intubation in your OT. And of course, the blood products should be arranged because these patients bleeds a lot. So complete clinical evaluation of these patients like spinal involvement, pelvic obliquity, limb length discrepancy, contralateral hip, bilateral knees, and integrity of the sciatic nerve has to be assessed prior to the operation. Activity level and the expectations from the patients is very, very important to know prior, because to make counsel your patients about the the result of your operation and what you are going to give him. So radiology, the whole spine and the pelvis, the X-ray should be done. In case of any spinal involvement, the pseudoarthrosis of the spine, a spinal consultation must be taken prior. CT scan is very important in ankylosed hip, especially the 3D reconstruction, in which we can assess the pelvic obliquity, which is very common in these cases. Bone stock, of course, we can assess. Medial wall, which is very important, which is very thin in these cases. Femoral canal diameter can be assessed by CT scan. By templating, of course, we don't do usually not very frequently, but we can assess the femoral size, cup placement, rotation and obliquity. Directly we cannot assess accurately by templating, but in some cases modular implant may be needed for the proximal femoral morphology. So if the patient is on methotrexate, he can continue methotrexate, but if he is on anti-TNF alpha, just withdraw those drugs 4 to 6 prior to surgery. So coming to the technical considerations, we need to know the positioning of the patient. Of course, lateral decubitus we do. Femoral neck cut is very important. Original joint line identification. While reaming, it is very difficult to achieve the original joint line because this is completely ankylosed. Acetabular component positioning, which is very important, and adequate soft tissue releases. So lateral decubitus, we give with the sacral and pubic support. And about the exposure, one thing I want to highlight is if there is an external rotation deformity of the patient prior to surgery, preferably don't go posterior because visualizing the neck is very difficult from the posterior approach. So go from the anterolateral. Tissue releases, definitely adductor tenotomy may be needed. Iliopsoas muscle release is a must because each and every cases of ankylosed hip, there is a flexion contracture. Gluteus maximus release, and sometimes anterior capsulotomy has to be done. So forcible correction of the flexion contracture with, if you have not done the soft tissue release properly, then there might be a fracture of the spine with neurological deficits. So be careful about that. And in flexion deformity, sciatic nerve is always at risk, which has to be sort of. So about the femoral neck osteotomy, there is a very popular V-neck osteotomy cut, has to be done to visualize the neck properly and to ream, because you will not get enough space to reaming in an ankylosed hip. So you have to make a space over there for proper reaming. So about the acetabular preparation, direction of the reaming can be IITV assisted. Never ever hesitate to take the help of image intensifier while reaming. So in this way, you can assess the proper inclination, proper antiversion, and the obliquity in which you are going to ream. So fixed pelvic obliquity, definitely there is an abduction deformity. You have to assess the reaming in the fixed pelvic obliquity cases beforehand. If the contralateral hip fixed in abduction or adduction deformity, determining the true inclination of the acetabular cup is very, very difficult. So you have to determine like whether you have to ream cephalad or the caudal. And the pelvis is tilted cephalad if the contralateral limb is fixed in an abducted position. So here is some cases, a 27-year-old male which has a right hip enclosed. It's an AP view. So it has been done successfully with a THR. Another case is a 22-year-old male enclosed left hip with an external rotation. So that you can see very well that the limb is completely externally rotated, in which we have to take care of the exposure and V-tape type of osteotomy. These are the lateral views, immediate post-op, and these are the bilateral THA in this patient. So this young boy was completely bedridden for more than 3 years, and then the bilateral THA has been done, and now he's able to walk properly. This is a case done by me around 18 years back. Just wanted to show it, like aseptic loosening has been done, and he needs a revision. So that's why in a bilateral enclosed hip, there is a bone is very, very osteoporosed. So they might fail after a few years because of the osteoporosis and the aseptic loosening. So coming to the complications, there is anterior dislocation hip is very common in these cases, and susceptibility to spinal fractures, which I have told you earlier, that release of the flexion contractures are the must. Sciatic nerve palsy, in one of the cases I got it even after full release of the flexion contractures, but there is some adhesions were there, and by correcting the deformity and reducing it, finally I got sciatic nerve palsy. So intraoperative fracture at the level of the calcar femoral is one of the complications, and these fractures have been managed successfully with circumferential wiring. Aseptic loosening, there is a main reason for revision surgery in patients with ankylosing spondylitis because of the less bone stock, osteoporosed bone stock, and heterotrophic ossification is very common postoperatively in these cases. So another case, a 26-year-old male with the ankylosed hip, is a lateral view. THA has been done. If you'll see it very clearly, this is one of the complications that the medial wall has been got fractured. So while reaming, it was not, while I was doing it, I could not assess that the wall is so thin that it got it fractured. So again, I have to put some bone graft and augment it and then do a THA. And weight bearing was delayed in these cases. So my take home message is, when you are doing a THA in ankylosed hip, proper assessment is of utmost importance in these cases, and adequate exposure and flexor releases are very, very important. Restoring biomechanics of the hip is utmost important because the biomechanics is completely distorted in these cases. Identifying the true acetabulum. So never ever hesitate to take the help of image intensifier in these cases. So that will guide you whether you have reached the true acetabulum or not. Inclination and anteversion should be taken care to minimize chances of anterior dislocation. So when you are doing it, that decrease the anteversion, so it will minimize the anterior dislocation. And cemented versus uncemented, it's surgeon choice, but good long-term survivorship has been reported with cemented total hip replacement.
Thank you
very
Thank
much.
you, Dr. Rajeev. It was a good topic with good presentation, and this is the time for Dr. A.K. Sinha. He will be presenting